Welcome to SpireCut's ultra-minimally invasive trigger finger surgery. We refer to our procedures as pinhole operations because the entire surgery is done through a simple skin puncture. The next day, patients have no dressings, can wash their hands, and resume daily activities. This patient was operated on yesterday of her right ring finger. This is her surgical wound. How can we safely perform carpal tunnel and trigger finger surgeries through a pinhole? Our instruments, guided by ultrasonography, were designed by surgeons specifically for these surgeries. This makes the operation safe, likely even safer than open surgery, as well as efficient and quick. The physician must be skilled in hand ultrasound. There is a range of difficulty in sonography-guided percutaneous operations. We recommend starting with the simplest procedure, A1 release of a long finger for trigger finger. The middle and ring fingers are the easiest. Once confident, move on to the trigger thumb and carpal tunnel. Do not begin with the trigger thumb or carpal tunnel. Remember, there are two models of sono instruments. Use the TF model for treating trigger finger. TF stands for trigger finger and is clearly marked on the box and the instrument's handle. The rod is just 1.5 millimeters in diameter, enabling the entire pinhole operation through a simple puncture made by a 14-gauge catheter. The instrument's bent shape suits adult flexor digital sheath anatomy. Do not use the sono instrument for pediatric trigger finger. This is the cutting extremity, effective on the tense fibers of the annular pulley but not sharp enough to unintentionally injure a tendon or digital pedicle. Note the small lateral flange on the cutting extremity that reflects echoes for better ultrasound visualization. Under ultrasound, you see two lines, with the cutting extremity between them. Remember, this part does not cut. If you attempt to cut the pulley with this part, you will need to apply a lot of force for inefficient cutting. The instrument is designed to gradually cut the pulley with minimal force. The rod has a spiral groove, visible under ultrasound as an irregularity on its surface and by two shadow cones whose distance changes with the instrument's rotation. Let us now explain how to operate on a long finger trigger finger. First, will you perform the surgery in an operation room or your office? SpireCut's method is especially suited for office surgery. You need a modern ultrasound machine with a high-frequency linear probe of minimum 12 MHz. A hockey stick probe is ideal, as the instruments might interfere with a conventional probe. Ensure your patient is comfortably positioned. You and your patient must be comfortable. Place the patient's hand on a side table. Hold the sonography probe with your non-dominant hand, and use your dominant hand for the surgery. This will determine whether you sit near the patient's head or abdomen. If an assistant helps you, that person will sit opposite you, but you can also proceed alone. In non-sterile conditions, perform an initial ultrasound scan to orient yourself, reversing the image if needed. The A1 pulley, where impingement occurs, is at the level of the metacarpophalangeal joint, about 2 centimeters proximal to the MCP flexion crease. So, the first step is to locate the joint. In the sagittal view, here is the metacarpal head, the palmar plate, and the proximal phalanx with its characteristic concave shape. Superficial to the palmar plate, locate the flexor tendons. Here is the profundus, and here is the superficialis. Normally, the tendons move synchronously during finger flexion extension. Superficially, locate the A1 pulley, which is typically a very fine structure surrounding the flexor tendons but not moving with them. It is flat on the sheath side and convex superficially. The pulley starts at the level of the metacarpal metaphysis and ends at the level of the proximal phalanx metaphysis. If the pulley is not clearly visible, flex the finger slightly to move the flexor tendons, then move your sonography probe a bit laterally, and it should become visible. In sagittal view, what are the pathological changes in cases of trigger finger? Firstly, the motion of the superficialis is altered. It no longer moves synchronously with the profundus as it is blocked by the annular pulley. Sometimes, the tendon echostructure is abnormal, and occasionally, a true nodule is present. At times, the tendon fibers are crimped, creating a focal area of tendon anisotropy visible under ultrasound. The A1 pulley is often thickened. Please measure the thickness of the pulley now. Here it is 1.2 millimeters, significantly above the normal value of 0.6 millimeters. Thickening varies from one finger to another. In the middle finger, the pulley is often relatively thin despite triggering. Now, proceed to the axial view. First, orient yourself. Identify where the ulnar and radial sides are. With some pressure on the probe, you should easily locate the digital arteries. The nerves are close by. For the long fingers, the pedicles are relatively distant from the flexor tendon sheath. Examine the flexor tendon sheath. The tendons are quite anisotropic, so adjust the orientation of your probe until you clearly see both tendons. The bones are your landmarks. From proximal to distal, identify the convex metacarpal bone. Then beyond it, at the level of the joint, you'll see the palmar plate, and more distally, you'll find the base of the proximal phalanx, which is concave. At the level of the palmar plate, the thickened pulley causes an artifact known as the Mona Lisa. It is not fluid, but rather a cone of shadow generated by the thickened pulley. Are you certain now that the patient suffers from true trigger finger, related to the catching of the superficialis on the A1 pulley? Remember, there are other causes of triggering, such as locked finger, extensor tendon instability, or other diseases. Occasionally, particularly in cases of Dupuytren's, the impingement is with the A0 pulley in the distal palm, proximal to the A1 pulley. If this is the case, remember to also perform an A0 release after the A1 release. It is now time to proceed. You do not need a set of surgical instruments nor a tourniquet. Avoiding a tourniquet offers many advantages, including no arm pain, better visualization of the pedicles, and less postoperative edema. Bleeding is not expected, and if it occurs, it will not obscure the ultrasound imaging. Proceed now to disinfection and draping. It is convenient to use the Sonopak distributed by SpireCut. Place a thick sponge under the hand to stabilize it and maintain the MCP joint in extension or slight hyperextension. Cover the hockey stick probe with a sterile cover, but first ask the nurse to apply some gel on the probe. It is important to avoid any air in the cover. Pour gel on the hand superficially to the pathological A1 pulley to be operated. Proceed now to local anesthesia. Choose a 10 milliliter syringe. Pour about 5 milliliters of lidocaine 2% into your syringe, ensuring no air bubbles are present, which could create artifacts. Use then a very thin subcutaneous needle. Bend the 23-gauge needle, making sure the bevel faces the tendons while you hold the syringe in your dominant hand. Apologies for insisting, but ensure you hold the syringe this way, or you won't be able to inject the local anesthetic with one hand under ultrasound guidance. Inform the patient that you are about to perform the injection and warn that it might be slightly painful. Perform the injection at the entry point, located at the MCP flexion crease of the long finger. Inject the lidocaine under ultrasound guidance, from distal to proximal, first subcutaneously just superficial to the flexor digital sheath, then deeper to the annular pulley. The injection into the sheath may cause transient pain, and you can see under sonography the fluid flowing along the tendons, which usually enhances the visibility of the pulley for a few seconds. Now that the patient no longer feels pain, this is an excellent opportunity to evaluate for triggering. Ask your patient to fully flex the finger. Sometimes, triggering that was not obvious without anesthesia becomes apparent as it was previously too painful. The Sono instrument is not designed to perforate either the skin or the tendon sheath. For this purpose, we use a 14-gauge catheter. Insert the catheter almost horizontally at the entry point, where it perforates the tendon sheath just distal to the A1 pulley. The catheter's tip is precisely located by making slight rotations of its bevel. It perforates the tendon sheath just distal to the A1 pulley. Following the retrieval of the catheter, the trigger finger sono instrument is introduced through the hole made by the catheter. Initially, keep the instrument's bevel parallel to the skin, but as soon as it is within the sheath, perform a 60 degrees rotation to align the bevel perpendicularly to the pulley, facilitating its release. The release is carried out progressively from distal to proximal, and it is performed in the safe zone, namely, the palmar midline at the apex of the pulley. During the release, you may hear some cracking sounds, which are also clearly felt by the patient. The complete release takes a few minutes. Remember, this is the cutting part of the instrument. Do not attempt too much cutting at once. Instead, advance the instrument incrementally beneath the pulley, then lift and pull it back slightly. The goal is to cut the pulley progressively. You do not need to apply much force. It may take about 10 cuts to fully release the pulley. Do not attempt to cut too much at one time. Also, remember that sometimes you need to cut the A0 pulley. Once you are at the apex of the pulley, lock your hand holding the sonography probe and use your other hand to cut the pulley. It is essential to see under sonography the whole length of the sono instrument, ensuring that the instrument is in the plane of the probe. At the end of the procedure, retract the sono instrument and verify that the entire pulley has been adequately cut. Well done. Now check if the patient can fully move the finger without any triggering. Is there any bleeding? Usually, the section is quite avascular and no bleeding occurs. However, we recommend applying a compressive dressing for a few hours to prevent the formation of a hematoma. It is permitted for the patient to wash their hands the day after the procedure. We advise passive proximal interphalangeal hyperextension motion exercises for the first 3 postoperative weeks to prevent joint flexion deformity. It is not unusual for patients to experience persistent pain upon active finger motion for some time after the procedure, even though the triggering phenomenon has ceased. This is likely due to persistent friction between the superficialis and profundus tendons. Let us now explain the specifics of trigger thumb release. Remember, start your experience with long fingers before attempting thumb surgery. Percutaneous trigger thumb surgery is highly rewarding, as most patients are very satisfied, regaining full motion quickly and experiencing no postoperative pain. This is likely because there is only one flexor tendon involved. However, positioning for this procedure is less straightforward due to the thumb's anteroposterior position. You will need an assistant to hold the thumb in metacarpophalangeal extension. Also, be cautious of the radial digital nerve of the thumb, which occasionally crosses very distally, at the level of the A1 pulley. Fortunately, this thick digital nerve is well seen under sonography. Pay attention, however, this nerve is very mobile, and by pressing hard with your sonography probe, you may displace it in the operation zone. In any case, you can orient the sono instrument and cut where it is safe, at some distance from the nerve. Under ultrasound, the appearance of the MCP joint differs. In the plane of the flexor digital sheath, a sesamoid bone is visible. The entry point for the procedure is not at the metacarpophalangeal crease, but rather at the mid-proximal phalanx. We hope this animation has been helpful. SpireCut remains at your disposal for further information or suggestions for improvement. SpireCut sono instruments are available to healthcare professionals who have undergone training and are experienced in hand ultrasonography. This video is not a substitute for the detailed instructions for use, which also outline the indications and contraindications.